some of the classic discussed findings, including some mild vocal edema and erythema. So this is the kind of patient that we face in our clinic every day, whether you're seeing them for therapy or in the laryngology clinic, where they have some hoarseness, they have symptoms, and in this case, there's a pretty convincing clinical diagnosis in that she's medically responsive, but she doesn't want to be on the proton pump inhibitor. So when we think about these patients in general, I would say if you have to remember one thing about this entire topic, not just this seminar, but the topic, I would suggest this, and I don't know that everyone agrees with this, but the clinical diagnosis of reflux affecting the larynx should be based on positive clinical history and examination. It should not at all be used as diagnosis, diagnosis used when you just can't figure out what's going on. And frankly, I think that happens a lot. One of my colleagues quoted was quoted saying, reflux has made us stupid. When we can't figure out what's going on, often these laryngeal disorders and diagnoses are attributed to reflux. And I think that's a shame, because I think there is a lot to learn to be said about this, but I think being careful and shrewd about the diagnosis is really more important. And that's the lesson I hope we can further along in this discussion. Why are reflux patients hoarse? Well, we do see discrete structural lesions such as pseudosulcus, granuloma, Rinke's edema, vocal nodules even have been associated with clinical diagnosis of reflux. And some of the more common things, which are non-specific to reflux, are vocal edema and erythema. In fact, these two findings are some of our better findings that have an association with pathologic laryngopharyngeal reflux. One thing I like bringing up is when we think of symptom correlation, we like to think of not just reflux findings, but the direct effect of the refluxate on the larynx, but think about reflex as well. We know that the foregut is interrelated in terms of neural connections, and while the possibility that something backflowing into the esophagus will light up reflexive changes in the larynx, such as a little bit of reflux into the esophagus will tense the vocal cords, we know that that's physiologically true. We just don't know how important it is clinically. So I say the significance of reflex, the reflex constriction, for example, of the larynx in facing a reflux event lower in the esophagus, the significance is reasonable to consider, but the scale is not clear. We don't know if it's a big effect or a small effect. We just know that it's an effect, probably. It may be a part of muscle tension dysphonia. It may affect breath support. We know that reflux, for example, in the esophagus causes airway constriction experimentally. So it's just more to think about when we're putting together the story in these patients. So we're going to talk about these with Dr. Hillel, but why do existing prospective double-blind placebo-controlled proton pump inhibitor studies, right, the best kind of medical studies we can do, why do they regularly fail to show consistent significant benefit for proton pump inhibitors used in to treat voice problems or chronic laryngitis with vocal symptoms? I always wondered, is it an education effect, right? Is it that folks are being seen and evaluated, they get their larynx looked at, and they're more interested, they're taught about vocal hygiene, for example, and it mutes the impact of medication? I always think that's a possibility. The AstraZeneca, the big study that was published in 2006 with esomeprazole, with a really big study, had pretty limited, modest entry criteria. They had a low bar to enter as chronic laryngitis, and they may not have been treating the most impacted patients, so harder to show a difference. Or perhaps we're just wrong, which is certainly, I think, part of the problem. It is not as big of a problem as many of us, myself as a laryngologist and my colleague otolaryngologist. Maybe reflux affecting larynx isn't as big of a problem as we think. I think that we have to be candid with ourselves that that's a real issue. When patients fail medications, is it because they have an incorrect or incomplete diagnosis? I think that's quite common. Their symptoms aren't better, but it doesn't mean reflux isn't the problem. It just may not be the only problem. There may be inadequate treatment. Some patients need surgery. They need more than medical treatment. They have inadequate hygiene. The person who faithfully takes their proton pump inhibitors twice a day, but they're still drinking a pot of coffee a day. Could it be the sequence of treatments? They need some muscle tension retraining from the speech pathologist, which they've had, and they didn't think it worked, but they really have some reflux component, and then they take the PPIs later. But they never really had both at the same time. Sometimes we see this in patients with paradoxical vocal dysfunction, muscle tension, that really each issue is important, but the sequencing really has to be right for patients to get better. Neil Chetta, a former fellow, I think I spelled that wrong, I'm sorry, a fellow with Dr. Postman, now at University of Florida, had a very interesting study showing that only about 57% of patients were taking their proton pump inhibitors correctly. That's probably a big issue. It's not wildly different than other chronic long-term medications, but it is something we need to consider, correct patient medication use. And the whole issue of non-acid reflux, which I'm not going to go into in any more detail. So the clinical diagnosis, as we turn it over to Dr. Hillel in a minute, the clinical diagnosis of reflux affecting the larynx should be based on positive clinical history and examination. That's my personal conclusion, not based on anything I've shown you, but I encourage people to consider the indirect effects of reflux aid on the patient's symptoms and focus on medication compliance and hygiene, and beware of the alternatives that Dr. Jobe is going to talk about, to alternatives to medication, including healthy lifestyle, surgical treatments such as insulin fundoplication, and the others that Dr. Jobe will talk about. As I say, the firefighters don't have to stay at the fire after the fire is put out. Many of our patients are on proton pump inhibitors for a short period of time. They should be used as a diagnosis of mind. We should focus on compliance and work with the patient to decrease and discontinue the meds once their symptoms have resolved. I think that's a good approach for these patients. I'll save that case for afterwards. I'm going to turn it over to Dr. Hillel to take on the next phrase. So let's see if I can do that here.
Thanks, Al.
Yeah, while
yes.
you're switching over here,
Yes,
just going to chat a little bit about what you mentioned earlier. I think that it's actually quite important what you mentioned about the issue of these studies. I don't know, Zandy, are you planning on going over some of the details of how these studies are done?
Yeah, briefly, mostly focusing on the results of the studies.
Okay, good. And I think that you mentioned a very important point, which is essentially that your research is only really as good as your basis of how you design it. And I think that hopefully we'll, as we learn here from Zandy, we'll understand that some of the research is fundamentally flawed, and that's what leads to some of this confusion. Plus the fact that this is not a straightforward slam dunk type diagnosis. It's difficult even in the most experienced hands. And so I think we all have to understand that, and it takes a whole bunch of different data to put together to really come up with this diagnosis properly.
Great, thanks, Milan. Thank you, Zandy, for joining us.
Thank you. Are my slides visible to everyone?
Yes, sir.
So I'll be touching on the risks of proton pump inhibitor use. I've got nothing to disclose, and what I'll be talking about is to briefly touch on the impact of laryngopharyngeal reflux in voice disorders, building a little bit on what Dr. Merati presented. And then before reviewing some of the larger prospective cohort studies and meta-analyses that assess complications from proton pump inhibitors, I'll introduce and explain some of the clinical meanings of the statistical methods used in these studies to help you understand really how to interpret the data that I'll be presenting. So laryngopharyngeal reflux is associated with a number of voice disorders, irritable larynx, vocal process granulomas, laryngitis, laryngospasm. We saw from Dr. Merati's presentation a number of other voice disorders. These are common symptoms: AM hoarseness, acid brash or halitosis, excessive phlegm, chronic throat clearing, and nocturnal cough, and then some of the more traditional GERD symptoms, heartburn and or burping. And really, testing is one area in laryngopharyngeal reflux that isn't so objective. The Restec pH probe, which is placed transnasally, has limited validation and a poor correlation with dual pH probes, which really limits us as physicians to treating with an empiric PPI trial to really determine clinically if the patient has laryngopharyngeal reflux. And before going into some of the complications of that therapy, what I'll be touching on is just some of the vocabulary I'll be using, as well as briefly describing some of the larger studies and the study types and how to interpret them using odds ratios, hazard ratios, and confidence intervals. So briefly, many of you, all of you, I'm sure know H2 blockers, such as ranitidine, and they'll be referred to as H2Bs throughout this presentation, PPIs, proton pump inhibitors, with the names of the FDA-approved PPIs and their commercial names in parentheses. Briefly want to just touch on study types that I'll be touching on. One is a prospective cohort study. That is really one of the strongest, most powerful study types that we have. And it's because it's a longitudinal study that follows a group of individuals over time to determine how a factor, in this case, PPIs, affect a certain outcome. Some of the studies I'll be presenting are actually meta-analyses, which group like studies, hopefully with the same methodology, to increase the power and precision of the data. I'll be touching on an odds ratio, which really gets at what is the odds of an increased outcome. And an odds ratio measures the association between an exposure, in this case a proton pump inhibitor, and an outcome, say a hip fracture. It's presented as a decimal, so odds ratios will be presented, the example I present here is 1.50, which in terms of understanding translates to a 50% increased odds of developing that outcome. The other critical statistic to look at, and is always presented or should be presented with an odds ratio, is a confidence interval. And the confidence interval should not include the number 1. In this case, the confidence interval is 0.85 to 1.95, just in this example, which means that the results are not significant. A hazard ratio is very similar to an odds ratio, and for all intensive purposes, in the context of this talk, should be considered the same thing. So over the next few slides, I'll be reviewing some of the common complications that we hear about with proton pump inhibitors and looking at some of these large meta-analyses and prospective cohort studies that assess the risk of these complications with PPI use. Common ones are bone fractures. And again, we think of osteoporosis as the risk from the reduced calcium absorption as a result of PPI use, but bone fractures are really the outcome, and hip fractures are a common one that we'll look at. Reduced vitamin B12 absorption, kidney disease, both acute and chronic, C. difficile colitis, dementia, and then I'll briefly touch on pneumonia. So I'll begin with looking at the risk of bone fractures. And these are large studies. In this case, this meta-analysis led by you et al. Grouped 11 studies with over 1 million patients. Of those 1 million patients, a little bit over 62,000 were using proton pump inhibitors, both men and women. And it showed a 16% increased risk of an any site fracture. And you can see here from the odds ratio, 1.16, with a 95% confidence interval that does not span 1. In this case, the range is 1.02 to 1.32. There was a 56% increased risk of spine fracture in this study and a 30% increased risk of hip fracture. Another study, this time a prospective cohort study published in 2012 by Hillel et al., showed that a similar risk of hip fracture with proton pump inhibitor use compared to patients who were not using PPIs. This study looked at about 80,000 women who were postmenopausal who had used PPIs for more than 2 years and demonstrated a 36% increase in hip fracture. When they grouped their study with 10 other like studies, that increased risk represented by a hazard ratio was 30%. And you can see a tight confidence interval of 1.25 to 1.36. They actually looked at other factors and found that smoking was a coexisting risk factor. And in postmenopausal women who were smokers who also used PPIs, the hazard ratio increased to 1.51, or a 51% increased risk of a hip fracture. Interestingly, those women who were not smokers but used PPIs did not have an increased risk of hip fracture. You can see, though the hazard ratio was 1.06, the 95% confidence interval spans 1, therefore wasn't a significant risk factor. So demonstrating a little bit of question to the risk of hip fracture in PPI users, postmenopausal PPI users who are non-smokers. There was another study looking at studying women in the study of women's health across the nation, or the SWAN study, that looked at bone mineral density. And as you can see, it looked at bone mineral density in the spine, the femur, and the hip, and showed that there was no significant difference in a hip fracture in H2 blocker users, represented by the middle column, PPI users, represented by the light blue column, or non-users, represented by the dark blue column. Nevertheless, this study was a little bit smaller in terms of the numbers relative to some of the earlier studies looking at hip fractures and bone fractures overall. Moving on to other malabsorption caused by proton pump inhibitors, there's a increased risk of vitamin B12 deficiency. This study looked at, by Lamb et al., looked at 25,000 patients with a vitamin B12 deficiency compared to 180,000 patients without, and found that there was a 65% increase in PPI users of 2 years or more of vitamin B12 deficiency, and a 25% increase in H2 blocker users compared to non-users. I list some of the symptoms of vitamin B12 deficiency at the bottom of the slide. There's also a risk of acute kidney disease with proton pump inhibitor use, usually acute interstitial nephritis that resolves when the medicine is stopped. It is not dose dependent, but should keep in mind that it can recur with a second exposure or with starting another proton pump inhibitor. More important is chronic kidney disease, because that, as you can see by the higher increased rate of end-stage kidney disease, which is not reversible. This study used the Veterans Affairs database to look at over 170,000 PPI users with a little bit over 20,000 H2 blocker users, comparing the two groups. And proton pump inhibitor users had a 28% higher rate of chronic kidney disease, and as I mentioned, a 96% higher rate of end-stage kidney disease. PPIs are also associated with enteric infections, namely C. difficile diarrhea, with a 70% increased risk of new infections and 150% increased risk of recurrent infection. What about dementia? So these are a couple of studies out of Germany that looked at over 70,000 elderly patients over 75, of which about 3,000 patients were on a proton pump inhibitor. And proton pump inhibitor users had a 44% increase in dementia. In a similar study, proton pump inhibitor users had a 44% increased risk of developing Alzheimer's dementia. And the last risk factor that I present here is the role in pneumonia, because that's another one we oftentimes cite to our patients. And observational studies have suggested an association between proton pump inhibitors and pneumonia. With odds ratio of 1.27 for all pneumonia, 1.22 for hospital-acquired pneumonia. But there was a large prospective cohort study looking at 4 million patients who were on NSAIDs, of which 2.3% were on a proton pump inhibitor. And in this large study, there was no increased risk of hospitalization for community-acquired pneumonia, as you can see by the confidence interval that demonstrates that it wasn't significant. So in summary, proton pump inhibitors have a real risk for malabsorption. We primarily see that with reduced calcium absorption, resulting in osteoporosis with an increased risk of bone fractures. Perhaps not as much of a concern in non-smokers. There's an increased risk of vitamin B12 deficiency, which is one I think we sometimes overlook. C. difficile is a real risk, and in patients that are on proton pump inhibitors who have diarrhea, the FDA recommendation is to test their stool for C. diff. Kidney disease, there's an association with chronic kidney disease, as well as an association with dementia, although further study is needed to determine if it's a causal relationship. And then pneumonia. I don't think the evidence is as overwhelming that PPI use is associated with community or hospital-acquired pneumonia. Thank you.
Awesome.
Hey, Zandy. So just take-home points for the audience.
So I think Jimi Hendrix is back on, guys. There you go.
Right. So just a take-home point for the folks that that take care of these folks on a day-to-day basis. When you get asked the question, essentially, at least the way patients ask me is, would you let your mother be on this long-term, forever? And what what would you tell your family member about the risks of this?
Yeah, I think that's a real concern. I think the take-home point from this presentation is really long-term proton pump inhibitor use. And as a clinician, if you have a high suspicion for laryngopharyngeal reflux, I don't think there's anything wrong with a short-term PPI trial.
What do you say short-term?
Short-term would be anything probably less than a year.
Okay.
Really as a way to assess, to clinically test. Dr. Merati earlier in the presentation talked about as we think about what could be the cause of their symptoms. Oftentimes patients coming in with globus sensation. Well, a 3-month or a 6-month trial of a proton pump inhibitor really doesn't pose the risks that are presented, that I presented earlier.
Yeah, we have a couple of questions also, if you don't mind me going through them. One question was in regard to that exactly. So if somebody's going to be on it long term, for example, the question was, any recommendation to routinely check vitamin B12 levels or suggest a replacement if PPIs are recommended for several months? Similarly, do you recommend patients be on calcium?
The calcium one I can address. The problem with calcium is that it's an absorption issue. So if you give more calcium, there is not necessarily means that the body is getting more of that calcium. So I think that's an important factor to consider. Rather, what I would recommend would be probably getting bone density studies to really assess for the effects of the proton pump inhibitors on the individual patient.
One thing I'd like to add as an echo, can you hear me all right, Milan?
Yeah.
Great. Is, in addition to doing exactly what you guys are doing, which is dealing with the patient that's on them, I think we should reemphasize the care that it takes to put people on them in the first place. The thoughtfulness that goes into the use, in terms of the clinical decision making. So all the more important that gets done correctly in the first place. Horse patients should have stroboscopy. They shouldn't just get told they have reflux. And I think I hear Dr. Silica clapping somewhere, but it's really important to do it right from the beginning. We can't always be sure, but we're going to save more fractures by getting the diagnosis right in the first place, even more than whatever we do once the correct patients are on them, and whatever reasons they're on them. So I think hitting it from the beginning and on the backside is really a great idea. And speaking of the backside,
this is Blair Jobe. Can you guys hear me?
Hey, Dr. Jobe.
Hi. I just want to echo what you just said, because I think one of the most critical aspects of this topic is really working together in a multidisciplinary way. It's really hard to know exactly what's happening in the larynx unless you know what's happening in the esophagus. And it's, I think, very critical that, we communicate with each other and work together to try and understand, is there esophagitis? I think the studies have borne out that, laryngeal examination outside of granuloma formation is really shooting in the dark when you put someone on a PPI trial. So I think in the end, it's critical that we all work together.
All right. Comment on that?
All right. I think you're right, Dr. Jobe, and thank you. I think teamwork. I'm lucky. I work with Carlos Pellegrini and Brad Olshager here, and we have a great team. I think there are some nuanced laryngeal findings that can be helpful beyond just granuloma, but I think your point is right. We have to be careful. And interesting laryngoscopy, according to one of the papers that Olshager did here, was that it was actually very helpful and predictive of symptom response in surgery for reflux. So you have to use the information correctly. I think you're right. Zandy, I think if we're going to move to Dr. Jobe, if Milan, when you're ready to move along, I think Zandy has to press the change presenter button.
Okay, there's a couple of more questions. I don't know. Do you want to get them at the end, or do you want to get them after Dr. Jobe?
No, I think it's good. Let's do maybe one more.
Okay, so it actually goes back a little bit to some of the early. I think this may be a Zandy question based upon what he was talking about, but the question really was about non-acidic reflux, and you'd mentioned the ResTech probe and pH monitoring. Maybe you can talk about a little bit about the role of impedance testing and what does non-acid reflux do, and what's your concern about non-acid reflux?
I think impedance testing is a good idea, especially as we're trying to get as much information as what's going on with the stomach and with the esophagus. In terms of non-acid reflux, I really consider it as something else to consider, especially if it's indicated from if the impedance testing is suggesting that that is a factor. I don't know, Al, do you have anything else you would add to that?
Yeah, you know, non-acidic reflux is somewhere between 1 and 99% of every patient's problem. It matters. It's not the monster lead problem in very many patients, but in our patients who have failed this, failed that, not getting better, then it goes up the list of concerns. We know that non-acidic reflux alone is injurious to the larynx, but it's not that PPIs don't affect. I mean, most pepsin, for example, is worse in patients who have acidity. So it's a double whammy. You take it with a reflux, the pepsin is still injurious, so it's not ineffective in treating it, in reducing the injury in those patients. But it is something that you should consider in patients who are just not getting better. And that's why surgery is particularly helpful in some of those patients. The hard part's figuring out who they are.
You know, one of the things when you're talking about pepsin, this is Jobe again. Sorry you guys don't get to see my face, but it's probably for the best. You know, when you're talking about pepsin, one of the things we've been looking at is the relationship between impedance results and pepsin in the hypopharynx in correlation with CEP70, which is a protective protein, and they're inversely relate. You know, there's an inverse relationship between those two markers, and what we found is that if you just measure pepsin, it's not going to help you. But if you look at the two things in relationship to each other as a ratio, then that ends up helping you in a high degree. And we're just getting ready to publish on this right now, and it's pretty exciting because I think ultimately there will be an assay that will kind of enable us to move away from things like impedance and ResTech and all of those testing modalities that are so flawed.
Awesome, exciting. Milan, what should we do? Move on?
And we can talk a little bit more as questions come up during that.
You know, I also think that non-acid reflux is a bit of a misnomer. Do you define it as people on PPIs who are having symptoms despite being acid suppressed, or do you define it as people who have symptoms with acid reflux going to non-acid as the saliva neutralizes the refluxate as it moves proximally? And I think
some people define it by just the testing itself, the impedance testing showing that the pH is neutral or basic, and yet there's still refluxate coming up. But it just depends on how you define it, and that's why I think what Al said is that it can be anywhere from 1 to 99% of the problem because it's not a defined problem.
Right. So I think in the end it's really important. I think impedance is critical in the diagnosis because as you can define acid to non-acid reflux. It enters the esophagus, it mixes with saliva, it moves toward the hypopharynx, and ultimately ends up leading to, injurious symptoms that are very, very elusive and very difficult to diagnose.
Yes, they are. Yes,
I'll add one more question because there was actually two questions in this regard. It's a pretty simple question just for some basic knowledge, but just from both of you, what do you consider an appropriate trial of PPIs in terms of dose and length? Al, you can start.
Yeah, so I don't have any wild ideas on this in terms of the duration other than 3 months, depending on the symptomatology. But even if they've been on it, it's only credible if their hygiene has been good, if their symptoms are related to voice and they haven't been better. What other aspects of it are under-recognized or under-treated? Did they already get the PPI from the previous physician, but they didn't have the therapy? Were they slamming the coffee? Were they? We have to really make sure the patient is really doing those things to say that patients, I think, a PPI failure or not. But 3 months is the duration I use, but I really try to hone the hygiene and then the sequencing of treatments to make sure we're really tuning all and getting all the plates spinning at the right time.
I would agree with Dr. Merati of 3 months. In patients who I have a high suspicion, I will sometimes go to a BID dosing of 40 milligrams. And I would also warn of the flip side to what Dr. Merati is saying is in the responder, how do we know that there's not a placebo effect? Because I think so many of our patients are coming into the office expecting a prescription for something, some sort of magic pill, and just by taking it, they're getting better.
When we have a patient that sees us in clinic and they have never been on a PPI, we have the balloons fall from the sky and all sorts of things happen. So it's pretty uncommon, but I hear what you're saying. I'm sure you're not much different in the clinic, though. So.
Okay, so what do we
at the risk of being this is Jobe again, but at the risk of being a bit controversial, there's two meta-analyses. One in the Annals of Internal Medicine, you should check that out. There's two meta-analyses that show that PPIs don't work in laryngopharyngeal reflux. And I think that the placebo comment was spot on. GERD is an anatomic problem. It's a broken gate. So if you have a broken gate and you're on PPIs and you're refluxing, your blood levels of that PPI are going to be variable throughout the day. And so you're going to reach a certain acidity that's going to enable pepsin to be active. You're going to have digestive enzymes. You're going to have multiple factors, bile, all sorts of things that aren't acid related that impact the larynx. And I think that we just need to change our thinking to understand better, that this is a problem that is suffering from a lack of diagnostic sensitivity. And
I have to disagree, Dr. Jobe, honestly. I have to disagree on part of what you're saying.
All right, go for it.
I don't think it's, I would say, as we were talking about, if you look at the cases, the studies that went into the meta-analyses, and this is sort of the typical arcane, in the weeds discussion on my part, but I really don't know that the entry criteria for many of those, the recognition of the disease, the involvement of the folks who are experts in the area from our perspective, has really been well fleshed out. And I would say the results are a little more mixed. So in my presentation, talked about the failure. We failed to show them how these things have affected it, and I recognize sharing with you that the placebo effect was significant, but I don't know that the disease is that difficult to figure out, at least from our end. From my end, I shouldn't say that, but I think it's something we can do. We just have to be thoughtful and careful. There are predictable clues. There are predictable things that we can talk about. So I don't think it's that difficult, but like I said, I mean, it is broadly speaking, it's something we just aren't there yet on our standpoint, as compared to where you are.
I think the thing that makes me scratch my head, and the thing that's so frustrating to me as a surgeon, is we do anti-reflux surgery on the people that you think are spot on LPR. They're referred to you. You do surgery on them, and they don't get any improvement. So, is that laryngeal hypersensitivity as a result of chronic disease? These are all rhetorical questions that I don't know the answer to. It's the more I learn about this, the more ignorant I feel.
No, I hear you. And without, I don't want to take some of your time talking about the procedure, but exactly teasing away which diagnoses are leading to which components, right? You can have a perfect reflux operation and yet have patients with symptoms. You know, what have we done for the patient? You know, so I think that's why the healthy discussion, same conversations I have with Dr. Oschlager and Dr. Pellegrini, just like you have with your colleagues there. So it is an ongoing discussion. Excited that that you and your colleagues are so compelled and interested in it.
Yeah, it's a passion.
Right on. Speaking of your passion, we wanted to hear a little bit about some of the things that you're working on in terms of from a procedural standpoint for this area.
Sure, I'm happy to talk about them. You know, the traditional approach to LPR has been, you know, once you think you have the diagnosis, to try and fix the problem, and it seems very logical that you would do a fundoplication. A fundoplication, for all of the people listening, is where you wrap the end of the esophagus with the top part of the stomach using a laparoscopic procedure. And that procedure has been shown to essentially eliminate any reflux. Patients who have that procedure cannot belch, they can't vomit, and it is a great procedure, particularly in the patients with typical reflux symptoms. When patients have laryngopharyngeal reflux, it's a little bit different because they're coughing. Some of them may have heartburn, but others may not. And so it's critically important to set expectations with those patients to tell them that, hey, you know, you're not going to wake up and necessarily be relieved of your chronic cough. It may take 3, 6 months, maybe even a year, and it may not happen for you. And so that's been the source of frustration. So really the approach that we've taken is that we use impedance pH, and the impedance catheter, for those of you that don't know impedance, what it does is it measures the movement of fluid from the stomach through the end of the esophagus, through the middle of the esophagus, all the way up to the larynx. And we use this in our institution. We use a specialized catheter that is placed through endoscopic guidance at the upper border of the cricopharyngeus muscle. So we don't really even care about Demeester score, even though that this placement system gets us within the sweet spot of Demeester score, within plus or minus 1 centimeter. So I think that when you have someone who has positive LPR based on normative data that we did, I feel like I'm kind of working in isolation because, you know, we're the only ones doing this currently. But if a patient has laryngopharyngeal reflux, regardless of Demeester score, we offer them surgery. But the important part of it is that we discuss with them that, you know, this is a new area, this is an area that's poorly understood, this is an area that you may not improve with intervention.
Can you just can I just stop you for a second? So you said that you have some criteria that you have for LPR, and then the other question is you don't use any other studies. That's all you need, and you can offer them surgery. You don't need a motility study, nothing like that.
No. So we run all of our own esophageal physiology testing components, which include an upper endoscopy, esophageal motility testing, because as we all know, a motility disorder can lead to laryngopharyngeal reflux just by capturing a bolus that you're trying to swallow and obstructing it functionally through aberrant esophageal motility that can lead to reflux and actual squirting of fluid out of the mouth in patients that have hypercontractile dysmotility. So it is a very thoughtful approach, but I was really keying in on the impedance because that's really all we have that shows, without a doubt, the movement of fluid from the stomach to the larynx. And this catheter is specially configured to help that happen.
Right, so I just want to clarify. I know that a lot of people probably have a little bit, are thinking twice about this for a second, but so you don't need endoscopy, you don't need manometry, you just need impedance that shows a significant amount of reflux events into the pharynx, and then some criteria, which I guess you'll define for us, as to whether they have laryngopharyngeal reflux.
No, that's not what I said at all. I tried to say earlier that it's a really thoughtful approach that uses motility, manometry, and upper endoscopy, and impedance pH.
Okay.
Yes.
So
we do the same thing. We do the same thing here, Dr. Jobe.
Mm-hmm. So you really have to look at it. You have to really look at all the aspects of esophageal function before you consider surgery on these patients. And but the clincher is the impedance, is what I was trying to say. And so
Gotcha.
the normative. So what we did is we basically used this impedance catheter in normal patients, and we tested them on and off PPIs. And what we found was that greater than 4 episodes to the high esophagus was considered outside of the 95th percentile of normal. And the secondary thing was that greater than 1 episode in 1 day was considered abnormal. And we tested these patients on and off PPIs with this impedance catheter. And so we use that as our benchmark for what is abnormal if a patient comes in. You have to keep in mind that the majority of patients that we see in our clinic are at the end of their rope. They've been to you. They've been to a pulmonologist. They've been to a gastroenterologist. They've been to a cardiologist. They don't know what to do, and many of them have become reclusive. They don't go to church anymore. They don't go out to eat because people think they're sick, because they're coughing all the time. And so what we say to these patients is, look, this is an investigational area that we're looking at, and we want to try and help you. This is what we think will happen, but at this point, we just don't have the concrete data that says, yes, this is the diagnosis. The treatment of GERD is easy, right? So someone comes in with heartburn, and their quality of life is terrible. They're committed to PPIs. They wake up and they're off PPIs and they feel great. People with LPR, you fix them, and the next day they're still coughing, and maybe a week
honestly,
later.
Dr. Jobe, it's funny because I'm sorry to interrupt. I think the treatment of LPR is easy. I mean, they're not hard to figure out, and surgery is a part of it. But when we work with our guys here, and I know you have the similar conversations, they might have somebody who, like you, needs something. They're at the end of the rope, and it's a miserable thing. Whether or not they're a performer that just can't get through the end of the show, or whether they're coughing in church, as you said, for example. And sometimes the conversation with the surgeon is, I'm pretty sure they have reflux. I'm pretty sure I can stop the gastroesophageal reflux. I can fix the mechanical problem, but I'm not sure it's going to help their symptoms. And so one of our duties on our end of it, if I don't mean to speak for Milan and Zandy, but is there any other explanation, right? Is there some other explanation than reflux that we can work on the symptoms and get them better regardless of whether it's neurogenic cough or there's some mechanical problem with the larynx? And so we can at least take the burden off the reflux treatment to say, well, this patient is going to get better because reflux stopped. I agree with you. I mean, we cannot expect these people to get better, but it's the hard part, I think, for a lot of folks is trying to determine what aspect of the patient symptomatology, whatever symptom it is reflux related. Because I've got my colleagues here who can do a great operation to fix the plumbing, but is it going to help the patient? And that's where the thoughtful assessment from the beginning, the symptomatology, the laryngeal exam, all those things will hopefully, ideally help get the right people to you, and then the right people back from you back to us, and help these people who are obviously suffering.
You know what? I agree with you 100%. But I think that the things that are offered in the voice clinic will not be effective until you control the reflux, because it's a vicious circle. We don't know what happens. When you cough, you reflux, which is why, looking at symptom correlation with impedance doesn't work. You cough every time you reflux. So is it the chicken or the egg? Did the reflux occur because of the chronic cough, or did the chronic cough occur because of the reflux? We don't know, and that's the really, really challenging aspect of this area. But I do know that voice therapy, those sorts of things, will not work unless you fix the reflux.
Well,
I mean,
again,
at least that, in my experience, maybe I'm seeing,
yeah.
it's possible I'm seeing a very biased population, and that's true.
Well, yeah, no, well, I think a lot of us work in environments. I think that's important. I think the idea that that there may be more to the story than just reflux is important. And again, it's interesting what you said surgically goes back to where we started, which was, getting the sequence of treatment. Is it possible that a muscle tension disorder of the larynx really has its roots in reflux, and you can do all the voice therapy in the world, but it won't get better until the reflux is treated? Or is it that they don't have structural problems from the reflux? They don't have stricture, tumor, scar, Barrett's, etc. And all I really need to do is cool them off and get them to voice therapy, and maybe they have a chance. It's those are the patients that do take this collaboration. I think you're exactly right.
Yeah, right. And just to add to what you just said is keep in mind that reflux is a progressive disease. So it tends to be very progressive. So over a decade, you go from Tums to Zantac to PPIs to nocturnal regurgitation and bile on the pillow. It's a whole spectrum, and so that shouldn't be underestimated in this particular area.
So, if you don't mind, I'm just going to switch topics real quick, just to ask you a little bit more about your expertise, because we had a few questions in this regard, but just to talk a little bit about the different surgical approaches, and then maybe also mention, I don't know if you do, but you probably do, the LINX procedure or the shred-up procedure, and what the value of those are.
Yeah, happy to. So, the gold standard is Nissen fundoplication, but, in someone who has LPR, when you do a Nissen on them, they have more bloating, they have more flatulence, they can't vomit. So, in some patients who have LPR, if they don't get a complete response, it's not as dramatic for them in terms of, wow, was this really worth it? So I think that's really important to discuss with your patients. The new kid on the block is the LINX procedure, and the LINX procedure is a series of magnetic beads that are placed laparoscopically around the junction of the esophagus and stomach as an outpatient. So the patient goes home the same day. And the idea is these patients have to have intact motility. So when they swallow a food bolus, the food bolus is pushed down through the esophagus, pushes into these beads and parts them through the proposile force of the esophageal muscle. So these patients need to have intact peristalsis if they're going to have a LINX. And so the food drops into the stomach and the LINX is drawn back together, thereby preventing reflux. The operation itself takes about 35-40 minutes. And the patients go home the same day. And so we've done this in patients with LPR and have had some good results, not perfect, and usually less than the patients with typical symptoms. The Strata procedure is a procedure where a device is placed, a tubular device is placed through the esophagus, and radio frequency ablation pins are deployed into the area of the lower esophageal sphincter, and energy is applied in that area. The idea of how it works is that it creates muscular hypertrophy, if you listen to the company. However, no one really knows how it works. The long-term results of this study or of this approach has been, sort of hit or miss. We use Strata, but we use it very selectively, and it's not really something that I rely on my day-to-day practice. So really 3 options currently. There's the Nissen fundoplication, there is the LINX procedure, and there's the Strata procedure. The endoluminal approaches, such as esophax, where you go in through the esophagus or through the esophagus, and you use devices, little H fasteners that look like price tag holders that pin the tissue together to recreate the valve. This approach is something that I was involved in the development of, but has really up to this point has not borne out to be something that's dependable and reproducible on a wide scale.
Great. So we are running low on time, and we do want to wrap up a little bit. I do want to just clarify a few things for everybody because I've gotten a lot of questions about these types of things, but just the basics really. You have a 58-year-old woman who comes into your office who's complaining of sort of typical LPR symptoms, throat clearing, globus. Where do you start with somebody like that? You start them immediately on reflux medicines. Al, you talked a little bit about dietary lifestyle modifications, and then what dose, how long, what types of things do you tell them to do, what not to do, and then when do you consider moving on? What kind of discussion do you have with them? Those types of things, Al, and then Zandy, and then maybe we'll pull in Blair a little bit about some of the complications and what to do.
Your chief complaint was what?
Globus, throat clearing.
Yeah, those are. I mean, if you have a patient who has globus, throat clearing, and they have certain historical features and certain exam features such as bookful edema and erythema, while non-specific, are helpful in supporting diagnosis. They have no other credible diagnosis that's part of it. They can be offered testing or empirical treatment with PPIs. Many of them had it already. Work on their hygiene and go for 3 months, see what happens. If they have concerning symptoms, dysphagia, red flag symptoms, things like that, then they may get some imaging, T&E, EGD, or esophagram. But otherwise, they just get treated empirically. But it's our job to make sure you think that's what they have, not just, I can't figure it out, then just give them PPIs.
Right. And then you treat them, if you do think it's LPR, treat them for a good 3 months, as you had said before. If they fail, where do you go?
If they fail, and I've scrutinized their, whether they've taken the meds correctly, et cetera, I then try to determine, do they have in globus, for example, do they have manometric evidence of UES hypertension? Do they have dysmotility, both of which can lead to globus sensation, even in the absence of acidification? So that's somewhere where I may go in that patient if I haven't had some anatomic imaging already.
Okay. And if it does work, and then the patient talks to you, Zandy, maybe, and says, well, I'm a 58-year-old woman, am I going to have a hip fracture? Do I really want to be on this stuff forever? What do you tell them, and what do you offer them?
Yeah, I'll put their fears to rest, that we have a little bit of time if they want to get off that medication. Certainly diet changes, smaller portions, watching what their triggers are can be very, very effective. And I'll really encourage many of my patients to move down that road. If that's not working and they're needing their PPI, and I think one of the questions that came up is if you're tapering somebody off, or how do you get somebody off a PPI? I don't think you want to go cold turkey because you're going to have rebound heartburn, and so it's something to keep in mind and keep informing the patient about. Getting back to your example. If the PPI is what's working for them and they want to come off of it, I think surgery would be very reasonable at that point, and getting them over to a GI surgeon is an option.
Okay. And then, Dr. Jobe, any other comments about that? Would you skip some of the earlier steps? Would you go straight to surgery based on what you're saying, or would you still go through the same protocol?
One thing I wanted to add is, with people with globus sensation, I would just be interested to see what the panel thinks of empiric dilation.
It works. I mean, empiric dilation works for globus. I mean, globus comes from laryngeal edema and UES hypertension, and you get symptomatic relief in some of these patients. It's not very well studied. If it's true cardiac achalasia, it does work. It just doesn't always work forever. I'm not against it. The interesting thing about the LES and the UES is, and you may disagree, but treating the LES can affect the UES. Generally, treating the UES doesn't change the LES that much. So if they
I would agree. I agree.
Yeah, so if you can do something better at the LES, there's a chance that UES symptoms, dysphagia, globus, etc., may get better. Not always, but may get better. So if they've got two things going on, I try to aim the energy at the LES, hoping the UES symptoms will get better. It's not always a clear cut. But
there was a mention earlier of the use of high-resolution manometry in the evaluation of hypertensive UES. In our experience, I just haven't seen many hypertensive UESs on manometry. And I think that, it's not a perfect technology, and you have a catheter a pressure transducer sitting in the middle of the lumen that doesn't interact with the tissue. And so I think it's difficult to identify objective criteria for hypertensive UAS as a source of globus.
Yeah, I think if we're also talking about globus and throat clearing, it is important to think about laryngeal hypersensitivity. As Dr. Merati has mentioned earlier, voice therapy would play a part in that. And one thing that really hasn't come up to consider would be a sensory neuromodulator like gabapentin, which can be effective in a subset of patients to help with globus sensation.
And the nice about the neuromodulator patients, generally speaking, the patients who will likely respond, who may not be responding to PPIs, they often are not that inflamed. The patients who have really more of a clear cut, you look down their throat, they're not that swollen. They're not that, however nonspecific it is, they look a little different not oftenly. There's no actual word.
When do you initiate that type of therapy? So again, going back to the same patient that we had, if they fail 3 months if you really do think they have LPR and you treat them for 3 months, is that what you try before you recommend surgery?
No, probably not me. I don't think so. I think if they've got it, and they have, if I put them on this medication, it's because I thought they had it, not because I didn't think of anything else. So if I think they have it, then they would probably go to testing.
Well, oftentimes, you mean reflux, right? But oftentimes the diagnosis of hypersensitivity is a diagnosis of exclusion, largely, right? So you're excluding reflux, and then you're going off into that realm of hypersensitivity, neuropathy, that kind of thing.
Yeah, although this gets, I feel like neuropathy is its own little part of the Venn diagram, whereas a hypersensitivity often is, as Dr. Jobe said, there's a bit of a chicken and egg thing there with reflux, and I think that's important to tease apart.
I also, this sounds a little bit, like heresy, but I don't think you necessarily have to have a positive Demeester score to consider anti-reflux surgery in a patient with LPR. A lot of these patients are having what we call the mist phenomenon, where they stand up, they're all upright refluxers. I mean, a lot of them are. The bipositional people who are regurgitating, who have LPR symptoms, are easy. We all know that. But it's the patients who, they sleep well, they get up in the morning, and they start coughing. And what we think is happening is those patients have a squirt gun effect, where when they stand up, the air and the fluid kind of mix together and squirt up to their larynx. That leads to LPR symptoms. And as we all know, you only need 2 or 3 exposures per week to have chronic symptoms. So it's a very elusive, kind of difficult area to understand exactly what's happening in that category of patient.
I'm delighted to hear that you and your center, obviously a big center with you there, and all your colleagues are interested in doing more and more, because these patients are often frustrated, and I think that's really valuable.
Yeah. So I think we're actually well over our time here, so we probably ought to close this out. It was a great discussion. Thank you, Dr. Jobe. Thank you, Dr. Merati and Dr. Hillel for doing this. I do think that there are lots of other questions, and there are some online. We may, after I guess this is over, we can probably answer a few of those questions as well. I hope.
Maybe the next one's in 2 weeks, or I've forgotten when it is.
Yeah, I believe it is, and it's on to muscle tension, correct?
Yes, and it's with Mike Johns and.
Yeah, the next webinar, September 13th.
Go ahead, Alison. Say the date again, please.
Next webinar is September 13th.
Right, and
September
the title
13th.
is Muscle Tension Dysphonia.
Right, with
Guys, muscle tension dysphonia is all GERD. No, I'm kidding.
Nice, that was easy. That was easy. Thank you, Zandy. Thank you, Dr. Jobe. Thank you, Alison. Thank you, Clark.
Thank you, guys. Thank you so much. It was an honor. Thank you so much.
Thank you, guys.
Thanks.